Hello everyone and welcome. My name is Andrew Jack from the Financial Times, and it's a great pleasure to host our discussion today. This is the 57th episode of the RSM's COVID-19 series, which is for health professionals by health professionals and designed to give workers on the front lines regular updates from healthcare leaders on COVID-19. So we're going to go into a minute into a discussion with Professor Sharon Peacock, the Executive Director and Chair of the COVID-19 Genomics UK Consortium. We'll have an initial discussion with Sharon, and then we're very keen to take your questions. So a reminder, on the Zoom call here, there's the Q&A feature. If you go to that, and please post your questions, and you can also look at others' questions and upvote them, which will help us prioritize and try to answer. A huge amount to get through, but we hope we can at least touch on some of the key issues here. And a reminder, of course, that the COVID-19, the Genomics UK Consortium, of course, first identified the new variant that we're now discussing so widely, and which has done much to change the progress and the challenges of tackling the pandemic in the UK and more globally around different countries. So let me turn now to Sharon. Thanks very much for joining us. And Sharon, first of all, just by way of background, explain briefly for us what Genomics UK, the consortium, is and how it operates.
Yeah, okay. So COG UK is a consortium of academics around the country. So we have 16 sequencing hubs right across the country. We also have all 4 public health agencies in Northern Ireland, England, Wales and Scotland, together with working with the Lighthouse Labs and the NHS. And the reason that we set it up, going back to April actually, so quite a while ago now, was to be able to provide rapid sequence data for the virus to inform public health decisions. So back then, the virus was pretty the same wherever you looked. It hadn't really mutated very much by then, but we knew, looking ahead and knowing about other viruses, that it was only a matter of time before the virus did develop a considerable number of mutations. So we were interested in both spotting those when they emerged and also using this technology for outbreak investigation. So it was a band of enthusiasts actually, and the history was quite interesting. We decided to go for it on the 4th of March, and fortunately by the 18th of March, the Sanger and our government had supported us in funding, and so we came into existence then. It's a group of around 300 people providing this service, and so far we've sequenced nearly 200,000 genomes, which compared with pre-pandemic is a pretty phenomenal number.
So talk us through a little bit the history of the discovery of this new variant, how it came about and what you've started to learn really about the history and the context and its characteristics.
Yeah. So the new variant that we focus on is the one that was first detected in the UK, in the south of England. So I think it's quite clear to me that we need to think about where things are first detected rather than where they first emerge, because it's difficult to know if many countries are not sequencing where things emerge, but we do a lot of sequencing and we first detected it in the south of England. Now, when you think about the virus, it's beginning to mutate. The differences in the virus starts to look like a spider diagram. It's quite complicated in terms of the changes that it's made. And so spotting any one mutation that might be important is a bit like looking for a needle in a haystack. And what you really need to be doing is looking really closely for clinical signals that a particular variant with particular mutations is causing trouble. So we have a lot of genomes, but actually the point at which we realized that something could be not quite right is in the beginning of December, when public health colleagues were investigating an outbreak in the south of England. And the curious thing about the outbreak was that the lockdown or the tiered interventions to stop people mixing seemed to be working in many other parts of the country, but in Kent, disease continued to spread. Now, there's lots of explanations for that. It could be that there's been a party or an event there's been a super spreading event. That's one possibility. But actually, when the genome was examined in relation to that outbreak, it was noticed that there was something quite different about it, in that it had 23 different mutations in its genome. And that made it really stand out to us. Now, 23 isn't a lot. It's actually got 30,000 different points at which it can mutate. But it was very unusual. It stood out from the rest of the viruses that are circulating at the moment. And it was at that point that it wasn't possible to definitively say that there was cause and effect, but it started a train of investigation to say, is this apparent transmissibility related to social circumstances, behavior, or is it to do with the virus? And so, as I say, that set off a train of investigation to work out if it was indeed the virus that was linked with greater transmissibility.
And what's our understanding now of perhaps where it first occurred, if you trace back?
It's actually, I'm hoping that one day I'm going to be able to give you the answer to that. But at the moment, we don't know who the index case was, i.e. the first person to have this virus. We know that it was detected first in the south of England. And so there are two possibilities, really. One is that it actually was imported from somewhere else. Now, what we know is that actually the UK is doing a lot of sequencing compared to many other countries. We've generated around half of the global genomes in the global open access database. So many countries actually wouldn't know that they had this particular variant. So it could have been imported and then spread from there. That's one possibility. The other possibility is that it actually did arise in somebody in the UK. And I think that one of the interesting, curious hypotheses, actually, and it is a hypothesis at the moment, is that some people who have impaired immune system can actually have chronic infection with COVID-19 and have the virus in their body for some period of time. And what people have observed in really case studies at the moment, just individual patients, is that such patients can have viruses that have changed quite a lot during the course of their clinical disease. So the alternative is that these events are associated with people who have got an impaired immune system. The virus is able to mutate over that prolonged period of time in the patient. And that's another possibility. At the moment, we don't know. And perhaps if we have the opportunity to go back and sequence lots of viruses in the future, we might know that. But it might just be left as an unsolved mystery.
So just give us a little bit on the terminologies and the definitions. I see there's, people have talked about shifts, about drifts, about variants, mutations. Where would you situate this?
Well, there's the terminology is it can be quite confusing. The one word that I try to avoid at all costs is strain, because that's not very accurate. It doesn't really describe what's happening. All of the SARS-CoV-2 viruses they're from the kind of original SARS-CoV that emerged, and so we should consider that as SARS-CoV-2. They're all SARS-CoV-2, so they're not a different strain, they're not a different type of virus, and so it's SARS-CoV-2. Now, when a mutation occurs, we use that term when a particular point in the genome actually it changes one of its points in the code, the genetic code. So there's a replacement. And when we really worry about that is when that replacement leads to a change in the amino acid that codes for, because that could change the biology. But that's what we call a mutation. And then you have combinations of mutations in the same virus. And so we're increasingly using the term variant, which actually characterizes a particular virus that's got one or more different combinations. There are other terms that are called that are used, including lineage. And that's really got quite a tight definition, but effectively it's a cluster of isolates that are very highly related. Now, you talked about shift and drift. So drift is, so you've got two types of kind of evolutionary mechanisms, really. One is that the change in the genome occurs quite slowly and incrementally. And that can be either a replacement or there can be a small deletion in the virus. We've seen that with SARS-CoV-2. But the alternative is actually viruses can actually recombine with related viruses, so they become sort of a new type of virus. And we see that with influenza, actually. So when we talk about different types of influenza, then that is when the virus is actually recombined bits with other bits. And that's also when new influenza can emerge from, for example, an animal reservoir. So parts of an influenza from an animal can recombine with a human and take on a different characteristic. So there's this kind of gradual change, and there's this kind of big leap in evolution. So those are the different terms that we think about. But what we're seeing with this particular virus is actually, it's really changing bit by bit. So what I would expect to happen largely is that the virus will when we, unlike influenza, when we take bit by bit, so that it all becomes, we have slightly different versions of the virus across the world and across even countries.
So if you compare and contrast it with other flu and indeed wider viruses that we know, how different or distinctive is the extent and the rapidity, for example, of the variation?
Yeah. So we know that the coronavirus, it can gain a mutation in its genome around once every 2 weeks. So, and that whilst it passages through people, then we expect 1 or 2 mutations every month. So that's the speed at which it changes. Other viruses, HIV, influenza, actually mutate much faster. Now, in the case of influenza, actually, that's why we need to have a different influenza vaccine every year. So we have to work out what the circulating influenza type is. And so we all have our flu vaccination of those people that have called for it. I think that in the case of SARS-CoV-2, what we're seeing is a sort of gradual change in the genetics and the makeup, if you like, of SARS-CoV-2. And so I think it's going to be much less orderly, if you like. There's going to be a gradual change in the virus. And I would say that most mutations don't matter at all and can be beneficial. So if the mutations accumulate and the particular virus is really quite distinctive and it's like a barcode of changes, then that sort of genetic fingerprint can be used to look at using it in outbreaks, for example. So a cluster of viruses that are very similar, they may have come from a particular outbreak, whereas if they're very different, then they're not. Most mutations are actually harmless to us. It's just the mutations that arise in parts of the virus that encode important parts of the virus, the spike protein, for example, which is the bit that interacts with our cells, goes on to enter into our cells through that mechanism, and also as the target for vaccines. Those are the ones we worry about. Most mutations don't matter, but what we're going to see is a very diverse population of SARS-CoV-2 over time, because they're busy kind of mutating as they pass from person to person.
In terms of our latest understanding of both what the variation has done to the speed and the efficiency, as it were, of transmission and impact on morbidity, mortality, what's your latest understanding on that? Well,
going back a bit, actually, back in April, there was a mutation that arose. It's called D614G, and that actually led the virus to become more transmissible than other viruses, and that's what we call went to fixation. So it pretty much is in all the viruses now that we see almost, and that was because it was increasingly transmissible. So that was like a dry run for us in terms of thinking about how we study that, how we develop the methodology to work out if it was more transmissible. But I think the thing that people will particularly want to hear about is the B1.1.7 that we first detected in the UK. The PHE call it variant of concern 1, so perhaps others call it VOC1. And that particular virus, I've forgotten the question, my mind's gone blank, please remind me.
Talking about the extent of both, the evolution of transmissibility and morbidity.
Yeah, okay. So there are several things you want to know about that virus. First of all, is it more transmissible? And very detailed and careful studies have shown that it is more transmissible, so it spreads more between people. And the estimates are about sort of 50 to 75% more transmissible, so about half again more transmissible. And that would explain why it's spreading so much. What we do know about this particular variant is that there is no evidence at the moment that it causes more severe disease. And so what we need to do in order to investigate that is to get the virus sequence from people who are sick and people who, and compare it with viruses that are other viruses that are circulating, and say, if somebody's infected with this virus, are they more likely to need oxygen, ventilation, or are they more likely to unfortunately die? We've got no evidence at all that B1.1.7 is more lethal in that regard. But that's the second kind of thing that we'd really think about. The third thing we'd want to think about is there any evidence that this mutation is important in vaccine escape, by which I mean less likely to be neutralized by the antibodies that we develop in response to natural infection or a vaccine. And there's no evidence at all at the moment that the VOC1 is not going to be susceptible to the vaccines that we're giving people. So that's good news. So in summary, then VOC1 spreads more, but that's the bottom line for it. It doesn't kill more people, and it's not going to escape from the vaccines that we're getting at the moment.
So we're going to shift towards questions. I see plenty have come in, and do please keep sending them or voting on others. But yeah, top of the list, Sharon, is indeed this issue of the efficacy of the vaccine, or indeed the vaccines, growing number that are out there. I mean, I wonder if you could go into a bit more detail then. I mean, you say there's no evidence so far. I mean, what evidence would we need? How would we even detect it? Or why can we postulate so far that it seems though this variant's not a threat to the efficacy of the vaccines?
Yeah, well, you can do experiments in the laboratory where this particular mutation can be artificially generated in a virus, and then you can see whether it's neutralized, i.e. sort of disabled, if you like, by adding sera from people who have had natural infection or have had vaccination. And that there is no evidence at the moment that this particular mutation leads to a lack of neutralization. But I think that going forward, what we really need to be doing is being on the lookout for other potential viruses that could escape vaccination or natural infection. And what we need to do there is, if people have had either infection before that they know of, or they've had a vaccine, if they develop COVID again, then we need to make sure that we sequence those viruses and look to see if there's anything unusual about them. Now, immunity to coronaviruses, then it doesn't last forever. And so we see the common cold, for example, this comes in waves and people lose their immunity over time and can get the same coronavirus again. That's likely to happen with SARS-CoV-2. But when somebody develops a second bout of infection, if they do, then we need to really look at that virus to make sure it hasn't got something that might worry us.
And obviously, immunology is a very complex science, but I mean, just going back to the vaccination for a second, though, any thoughts, though, as you say, one could do some laboratory testing, but nonetheless, any thoughts on, the potential implications for the different approaches to vaccines, or indeed the scheduling, with the one versus the second dose, for example, and how the variant, if at all, could affect that?
Yeah. Well, I think that I'll start with this scheduling first. So from my perspective, I don't think there was any other choice to make than the one we made. So there are a limited number of vaccines to give people, and a lot of very vulnerable people. So I think it was absolutely the right choice to say, vaccinate a lot of people, get a lot of coverage for the largest number of people. We know that these vaccines are highly effective after the first dose. They give a boost to the immune system on the second dose. So I think that scheduling is, I think that I entirely agree with that. In terms of the impact on the virus, once you start to introduce any kind of intervention into a population, then it will exert kind of a selective pressure on a particular organism. So, for example, antibiotic resistance is something we heard a lot about before COVID. And if you have an antibiotic, it's likely to select out something that's resistant to that antibiotic, and that's how it works. If you start to introduce a vaccine, then then there's selective pressure on the virus to try and find a way to kind of get around and persist, because that's what evolution is all about. However, our knowledge on vaccine development has actually advanced incredibly rapidly. It's quite extraordinary in the last 10 months. And I think that it's going to be a process of watching for anything that may escape. And then I think it's going to be a process of actually developing a panoply of different vaccines that could be provided. So I think it's possible that new vaccines will be required. I think that it's very difficult to judge at this point in time. But if something was required, then I'm confident, actually, based on everything we've seen, that the technology will be there to tweak the current vaccines so that they could become effective again. And I think that we're learning all the time about what the vaccines are targeting on the virus. So, mapping out the parts of the virus that the vaccine is working towards. So I think that, it is going to be something of a kind of cat and mouse game, but I feel confident that with the combination of sequencing and surveillance and vaccine manufacturers, then I believe that we can stay ahead of the curve.
So, I mean, just focusing on vaccines again for a second, as there's a question here on why should people that have had COVID also be given the vaccine? Slightly outside your focus, but probably
Yes.
worth touching on.
Yeah, well, I think that I've just sort of mentioned the fact that your immune response to COVID-19 is not going to be long lasting. It will not last for years, and we know that antibodies start to wane after a period of time, and we know that second infections can occur. And so, if you can get a vaccine and boost your immune response, then I think that's a good thing. And going into the future, I think that we're looking at repeated immunization over time, because we'll need to keep boosting our immune response. We've got quite a lot to learn in that regard. But what we do know from the common cold, for example, is that immunity does wane. And from early studies of SARS-CoV-2, there's a sort of similar sort of signal coming through in the data. So I think that we're looking at, it's not going to be a one shot and you're done. I think that we're going to need to keep coming back in the same way. It's a different scenario, but in the same way that people get their flu jab every year, we'll be looking at repeated vaccination of people.
So just doing a bit of compare and contrast, there's a lot of interest here in the variant detected in Brazil, which, as we know, could lead to closure of travel and so on very shortly from that. So how different is that one from the variant found here, and how much concern should this give us?
Yeah, well, certainly it is somewhat different. It's a different lineage. It's 1.1.28, and in fact, it's a branch of that. It's different from that again. So in Brazil, there are two main lineages that cause infection, and this particular lineage this one of concern is a branch of that. It's called P1 actually, which is quite easy to remember. And this particular branch of the Brazil lineage has got several mutations, which together may be of concern. So it's got the 501Y, that's the one that we know is in the VOC1 in the UK. And so we know from the UK that is associated with more transmissibility. So that's the first thing. The second thing, it has a mutation called E484K. Now, there's no evidence that is going to escape, the effect of immunization. But what we know from very early data is there's some suggestion that it could avoid some antibodies, monoclonal and antibodies raised in humans. This is not a kind of a complete loss of immunity, a long way from that. But it's sufficient to actually have people thinking, actually, you've got to study this in much more depth. And so as we speak, people are beginning to study this in the laboratory to work out exactly what the story is in immunity. So I think that I would say that this should be an optimistic message, that we shouldn't all start to be concerned. But what I think it means is that we've got effective surveillance mechanisms and information flow from around the world to allow us to actually spot when things are emerging. And I think the good news story is that through sequencing, we can see the changes in the genome. And then, as necessary, we can take public health actions to be able to contain this should we need to. So I think that as the virus mutates, this story will keep repeating itself. So we need to keep watching the genome. But this is why there's interest in Brazil. So I'd say I think the overall message is there's no reason to be to panic or feel alarmed, because there's no reason to think that immunization is not going to work. But it's of sufficient concern for people to start to study it in the laboratory in the same way that we studied VOC1.
The key issue, I guess, going back to the UK detected variant as well, is obviously that increased speed, isn't it? And therefore the public policy implications of much larger numbers more rapidly being infected, and therefore the burden on hospitalization, for example, more than actually mortality risk.
Yes. I mean, indeed, the fact that if a virus has the N501 background, what N501Y background, we know that it's likely to be, it could be more transmissible. So that already kind of rings alarm bells. And if it's then carrying other mutations that could have other properties, then clearly we need to take it seriously. But again, I would come back to the fact that we have the tools to detect this, and then the public health capabilities to prevent spread.
We talked about the variant detected in Brazil. What about that one in South Africa?
It's also got an interesting name. First detected in South Africa, B1.351. We call it VOC2. It's got several names. Actually, it's quite confusing. But what we know is that has got the N501Y, which is the transmissibility mutation, and it's also got the E484K. So again, both of those particular variants are undergoing a detailed investigation.
I did say, just for the record, where are we now? I mean, there have been examples of this variant detected first in the UK, in a number of other countries now, haven't there? Any big particular concentrations or early spottings in a number of other countries?
Which variant are you asking?
The UK, the one we started with.
The first one,
your first, exactly.
One.
Yes, VOC.
Yeah, well, there's the numbers I'm going to give you are going to be an underestimate, because we only know what we've sequenced, and we sequence slightly less than 10% of all the viruses that people are infected with. So this is going to be an underestimate. And the data is based on what's called GISAID, which is a global database which gathers genomes from all around the world. So what we know from that, for the VOC1, is that it's actually been found in 35 different countries now. And the sequence count in GISAID is just short of 14,000 genomes. As I say, that's an underestimate of its likely prevalence, because you only know what you sequence. But that's the situation for the variant of concern 1.
So just a question here around surveillance approaches. Can screening for COVID viral load in sewage be used as a monitor to predict outbreaks of the various mutations?
I think that studying sewage actually is a really important capability, particularly as when people are asymptomatic, they may not get they won't get a test because they're asymptomatic. But also wastewater can be really important in places that actually don't have the testing capabilities. So in low and middle income countries, and you can test wastewater, which drains from schools or hospitals or populations. And the level of detection for SARS-CoV-2 is around 1 in 1,000 people. So, you detect one of those out of 1,000 people infected. So you can take kind of wastewater from that's drained from towns or populations and work out whether there's disease in that population. Now, you're quite right. You mentioned that that's quantitative, and it can actually tell you how much virus is actually in that sample. But the other thing that that scientists are doing at the moment is they are looking to see whether you can sequence fragments of the RNA of the virus, and then it's RNA to DNA, so you convert it. But whether you can understand the genetic code of fragments of that virus in wastewater, and then through those fragments see whether you have particular lineages or particular variants. So that sort of work still underway, but there's a very strong wastewater consortium in the UK who are looking at that and working out whether you can certainly look for the presence of disease in a community, but can you actually go further than that and say what lineage is circulating, what variant is circulating, by looking at the fragments to look for whether the mutations you're looking for are present.
There's a number of questions about the sort of drivers, perhaps, of mutation. This one here goes back to the question of surveillance. So in the UK, South Africa, Brazil, in those variants, are those being detected because of better genomic sequencing, or because they're more virulent? Or indeed, are there any other particular drivers you think in those countries that might be explaining why there seem to be patterns?
Yeah. I suspect a large part of this is that there's very good sequencing capabilities in the countries where these have been identified. So certainly in South Africa, there's a very good sequencing group, and in Brazil, and you're only going to see it if you actually go and sequence. So I think part of it is detection. I think it would be not particularly plausible to say that there are particular populations in which mutations are going to arise. I think the one query in my mind is what I've already mentioned, and that is, and immunocompromised people are all over the world, not in one particular place. But if there are people who are immunocompromised, is this the population in which the variants are arising? And that's under close scrutiny now. So people, public health authorities are looking at people who are immunocompromised to say, is there more likelihood that a variant would arise that is of concern to others? So I think that it's likely to be mainly about detection, and at this point in time. But I think it's possible that people with immunocompromise could be in part of the story.
And a related question going back to vaccines then. So please comment on the risk of virus-resistant mutants when there's large numbers who are partially immune, specifically as a result of the implication is sort of, one of the 2 vaccination doses in the schedule, for example.
That's a tough question to answer. I'm not quite sure how to answer it. I mean, I don't think it's possible to assess the risk at the moment. And I think that that's something we'll obviously be thinking about. I think if you put a large number of people with partial immunity with a large number of people who are infected, then you can get crossover. So the virus gets an opportunity to sort of test out people's immunity, if you like, and try to find the kind of the potential gaps in their immunity. So I think a large number of people with disease, with a large number of people who have partial immunity, is a potential situation that we'll need to watch very carefully. But in terms of risk, I don't know how to quantify that at the moment. Perhaps my colleagues would be better at answering that. But I still maintain that the situation that we're in, where people are given the first vaccine and that more people get the first vaccine than a smaller number of people getting vaccine shot number 1 and number 2, is the right decision, because we can protect the large number of vulnerable people in the country more than if we were just to simply go 2 at a time.
And that would affect equally that idea of the impact of an increased phasing, so moving towards 12 weeks, for example, for the second dose as well.
Yes,
untested, but
yes, I mean, by the time you've had 1 dose, you've got pretty good immunity, quite frankly. So I think that I wouldn't want to speculate the kind of fraction of the difference that would make. But as I say, I'd stand by the decision that's been made that one vaccine protecting lots of people is the right thing to do. And as I say, one shot will give you a good level of protection.
So it's a question here, are we positively selecting for a more highly transmissible strain due to social distancing?
Golly, I don't quite know how to answer that. We have to social distance, we have to do that, and it's like wash, mask and distance is absolutely right. I would be surprised if that alone was a driver for selecting out a transmissible, particularly transmissible variant. I think that, I'm just trying to think through the scenarios where, because if you're more transmissible, it doesn't mean to say you can jump 4 meters rather than 2. It's exactly the same principle that the social distancing and the distance that you'd need to be away from somebody before you're out of the kind of the risk zone is exactly the same. So transmissibility isn't about kind of being able to kind of cross a divide between houses. And so I would say on best kind of judgment that I think it's unlikely that social distancing is really having a major role to play in the evolution of the virus.
And actually, this relates to the question about, please could you explain exactly how the virus has become more transmissible? Is it something about size of particles, the density?
Yeah, it's likely to be down to the host. So if you, for example, N501Y, it appears to have a better binding affinity to the human receptor that the virus attaches to and enters the body, ACE2. And so if you are better at binding, then I think you have an advantage over viruses that have lower binding. But in addition, we're looking very carefully for evidence that you get higher shedding. And so people may be more effective if they're shedding more virus. And so there's sort of different ways that you can become more effective. So you can be more effective at infecting people. You can be more effective at transmitting if actually the amount of virus that you're shedding is actually higher compared with other variants.
And so we've talked about transmissibility, which we know helps the virus survive. But question here, what about specifically the evidence on whether it produces less severe disease? Where's our understanding got to on that?
Well, at the moment, we haven't got any evidence that any particular variant causes more or less severe disease. Some mutations that arise in the virus will actually be so deleterious to the virus persistence that it actually will just become extinct. You won't actually see it in the population. But the idea that a virus could become more lethal, which is what it'd be great if it becomes less lethal, it could go either way, is something that we have to watch for very carefully. I think that there's a kind of a paradigm out there that perhaps, if you wait long enough, a virus will kind of mutate so that it can be transmitted, but it doesn't really harm the human host. But I think that I never take anything for granted with this virus, to tell you the truth. Some of the things that I've concluded early on in my own mind about the virus has proved to be not correct. I think you have to have a completely open mind and say, I don't actually know at the moment whether this virus is going to become less or more lethal. What we have to do is actually bring the science to bear to do that, and that comes back to watching very carefully your inpatient population in particular, and whether, as I say, you think your patients are doing less well than they were previously. I mean, the fact of the matter is that more people are surviving hospital care because doctors are getting better at understanding how to treat people, and there are drugs around, so dexamethasone, for example, that can be used to treat people. But I think that rather than guessing the future, which I'll probably be wrong, and then people will say, you said that and it was wrong, I'm quite happy to admit when I'm wrong, but I think that what we have to do is bring the science to bear and actually the surveillance to watch what's happening over time.
So people are asking questions about, again, sort of patterns. Any indications about the variant being seen in particular blood types?
The blood type actually has been a kind of interesting story, and it actually was raised very early on because, of course, that's a human characteristic, and a study very early on suggested that particular blood types might be associated with getting disease and getting severe disease. So that looked at human sequencing, human genome sequencing, but actually subsequent studies demonstrated that that was likely to be a function of the way that the cases were put together for the study, so that hasn't been verified. Now, would a particular variant link with a particular blood group? I think based on what we know, I think that's highly unlikely.
Okay.
And we have no evidence for that.
Right. Does the new mutation more easily infect people who've been previously infected with the old variants? Do we have enough data on that?
We don't. There are studies going on in the UK and elsewhere looking for reinfection. We're only just getting into this disease, as it were, and so getting reinfected would require your immune system for you to be susceptible to infection again. There is a very nice study that's just coming out called Siren, which is looking at the rate of reinfection, which I think is a very important study. But I think that understanding reinfection is going to be absolutely in the spotlight. So I think that we need to look at when people are reinfected, what they're reinfected with. There's one particular case study in Brazil where somebody has become reinfected with the new variant, and that has caused interest, but it's N equals 1. So what we need to do really is be really vigilant and say, has somebody got natural reinfection? Right, let's look at the virus. Now, if you get reinfected, it's possible that you don't have such severe disease and you don't actually know that you're infected at all, and that's part of the findings of Siren. But I think that if you ask me a year on from now, I actually might have a slightly more accurate answer. And in fact, I could probably say that for all the questions, because the evidence base we're rapidly assembling it, but it's not perfect yet.
Just a couple of other questions on demographic characteristics and whether there's any link with presence of the new variants by age, for example, or ethnicity.
Yes. I'm not aware of any difference in age distribution for the particular variant, and I think in terms of ethnicity, that's something that will continue to be looked at and reported by Public Health England.
So we're moving very much just the final couple of minutes, Sharon. I don't know if there's some very touching personal stories and talk about physicians on the front line, the challenges of healthcare workers and the policy issues, which perhaps a little bit outside the mandate of this discussion. But any thoughts you have really about the implications of what we know more generally on the future, our future functioning, and notably restrictions on movement, social distancing, and so on?
Yeah, well, I think that that a combination of genomes and surveillance is going to become part of our lives. Actually, we're just going to get used to the idea that we're kind of watching the virus and watching the genomes. I think that that I'm optimistic that the vaccine will make a difference in our lives in terms of the way we're having to live at the moment. Is there ever going to be a time when we're not really aware of washing our hands, covering our face, or social distancing? I think time will tell whether we can ever go back to an environment where we never have to have some sort of thought about viral spread. I think coming back to the personal stories, I want to say a huge thank you to all healthcare workers and social workers and others on the front line. I'm actually a non-executive director on the board of Adam Brooks Hospital, and so I'm very well aware of the sacrifices that people are making in terms of the commitment and the challenge of wearing PPE all day, the challenge of dealing with the current situation with hospitals that are very busy. And I just want to extend my huge thanks and gratitude to everybody for the work that they're doing. I'm really grateful.
No, thanks very much. Totally agree. Apologies that we've just about run out of time, Sharon. But thank you very much. I don't know if you had a final thought, just simply about what lessons from what you've seen currently in terms of the ability both to continue to tackle this pandemic, but also thinking about the scope for genomic analysis and surveillance for preparation for future pandemics.
Well, I would leave on an optimistic note. I think that things will get better. I think we've got fantastic science and scientists. looking ahead, I would really like to see the extension of genome sequencing across larger parts of the world. And so we have generated around half the world's genomes. And I think that if we can support others in their bid to do more sequencing, because they will find that information very useful, I think that we should do everything that we can do to encourage other people to start to use sequencing so that they can benefit and their populations can benefit from that new information.
So apologies that we've not been able to answer all your questions, but I think a really helpful kind of up-to-date insight and analysis into all the work you're doing. So Sharon Peacock, Executive Director and Chair of the Genomics UK Consortium, work around COVID-19. Thank you so much indeed. Thank you everyone for attending. A reminder, the next RSM COVID-19 webinar will be next Thursday, 21st of January, and that will be with Don Berwick, the former administrator of the Centers for Medicare and Medicaid Services under President Obama. We'll be looking at COVID in America, the end of the Trump era, and what we can expect for a Biden administration. So thank you all very much again, and stay safe.
And thank you for inviting me.